ways of studying the blood and to measure how much oxygen carrying capacity you have is to spin it down, okay? So this is a lot of blood that they show here, and sometimes they'll put it into vacuum vials, and if they need to do a lot of chem counts. But if all we're doing is measuring the hematocrit, blood is drawn up into what are known as capillary tubes. If you recall from when we did the sea urchin fertilization, we used capillary action to draw the fluid with the sperm into the under the cover slip. And so if you are, when we used to do this 25 years ago before HIV became prominent enough that it was too hazardous for students' health, although at Sac State, when I was teaching the Bio 431 equivalent there, the lead instructor was, well, these are nursing students, they need to learn aseptic techniques, so he would have them draw their blood for glucose testing and so on. And I was still a little leery because a few years before, a student had come in, stayed late, he was a diabetic, and he wanted to show me his new machine. And so so you don't have to just stab yourself, because students have a hard time doing that. They always would come up to me and say, will you stab my finger with the lancet? This was a new machine to do that, and so I put in a lancet and stabbed my finger, and it was red, the glucose was red. A little low, it's like 65 milligrams. It's supposed to be around 100, 105 or so. And so he said, well, let me read mine. And he stabbed his finger, and I looked at him and I said, you didn't change the lancet. And his face just lost color, and he looked at me and goes, you don't have anything, do you? I was like, not that I know of. But that just illustrates to me how quick and easy it would be for diseases that can be transmitted by bloodborne pathogens, and just not being aware of it. He was somebody that had used this all the time, but he wasn't used to sharing it with somebody. And so when we will do blood testing, we don't test as far as blood typing. You don't get to type your own blood. We have a fake blood that matches up with antigens and antibodies and so on. So I just wanted to pass this around. If you were to lance your finger and get blood to come to the surface, you're just going to put this as hollow on both, all the way through, open on both ends, and capillary action just draws it up into the tube. Okay? And so the next slide actually shows this a little bit more realistically. And then it's placed into a centrifuge. There's a little groove that takes the size of the tube, and it's spun for 3 minutes. All right? If, however, remember I said it was open at both ends, and if you put it into the centrifuge, open at both ends, you're going to have the inside of the centrifuge covered with blood, because it's just going to spin it right out. So to prevent that from happening, we have these little clay trays, just like modeling clay, and you just put your finger at the top of the tube so the blood doesn't run out, and you just push it down into the clay tray, and that blocks that one end and the other stays open. So would you put that clay in pointing to the center of the centrifuge or pointing to outside the centrifuge? Outside. So if you've ever gone around a corner really fast, you get thrown to the outside of the vehicle because of the centrifugal force. And so the material that's being pushed to the bottom of this fluid are the cells and the plasma proteins. But the cells are by far the largest and heaviest, and most of our cells are red blood cells. Okay, they number in the millions, whereas white blood cells are 5 to 10,000. This is per cubic millimeter, and platelets are about 500,000, 250 to 450,000. So by far, so the fluid that you see is mostly the red blood cells. The fluid above that is a straw color, and this is the plasma. Okay, so we call the proportion of cells or formed elements, because they're not all pure cells, the proportion of cells to the total volume of blood is known as the hematocrit. And it's given in a percentage. So if this is the hematocrit tube, the capillary tube, and the total volume of blood up there, and we measure it with a millimeter ruler. All right, so A is going to be equal to the length of the blood in the tube. You don't have to worry about volume, just because it was length. So all the blood. And then when we spin it down, we get a fraction that is just red blood cells. With a little white at the top where the platelets and so on are. So then that's measured in millimeters as well. And so B is going to be equal to the length of the formed element, the cells essentially. And the reason we say formed elements instead of cells is because the red blood cells have lost their nucleus, their nuclei, and essentially a cell membrane of hemoglobin without any other organelles. And the platelets are fragments that have been pinched off of a large cell that remains in the bone marrow. So the only true cells are the white blood cells, all right? This gives us a percentile. So 45% is going to be the formed elements, and it's less than that in most females. And 55% is going to be what we call plasma. Okay, I did this wrong. We don't divide the large. The small number is divided by the big number. Okay, to do this, we'll keep A and B the same. We're going to take B and divide it by A. Okay, to get it, this is a percentile, so it's going to be a number less than 1. So you're going to take the length of the formed elements and divide it by the total length of the blood volume, of the length of all of the blood. So 55% will be the fluid and proteins, and that's the plasma. Okay. So almost half by volume, not by mass, but by volume, is going to be the formed elements. And if we look at numbers that are more clinically derived, males typically run 40 to 55, about 48 is what most males would be, and females 36 to 48, although 38 to 42% is probably a more common range. Yes?
So is hematocrit is the end of the equation?
So, yeah, so hematocrit is a percentile determined by the proportion of formed elements divided by the total amount of blood. And it's abbreviated HDT, okay? So if I were to give you, when I had filled out handwritten lab reports, I would have a series of these, just darkened with different amounts of blood cells, and you would measure the length of this area in millimeters and divide it by the total length occupied by the blood, okay? So, a 38% would not be a low hematocrit for a female, but would be a low hematocrit for a male. Can you think of some reasons why a male typically has both a higher hematocrit and higher hemoglobin, which is measuring the amount of hemoglobin total with all the red blood cells? And they're very close. If you have a low hematocrit, you're going to have low hemoglobin. One is measuring volume and the other is measuring mass, but they're measuring the ability of the blood, to transport oxygen. So why would males tend to have a higher hematocrit and a higher hemoglobin?
Because we don't have a menstrual cycle.
Yeah, more muscle. So a greater muscle, then that's due to testosterone, okay? So with testosterone driving a greater muscle mass formation, that leads to greater oxygen use, greater oxygen need, and so the body has more red blood cells to perform that function, okay? Anybody know what organ releases a hormone that triggers increased blood formation? It's a hormone. It's the same organ that finishes the synthesis of vitamin D, which is also known as calcitriol hormone. No? Although part of it occurs there, but.
Kidney?
Kidney. studying it, but lots of blood flows through the kidney, so it certainly gets exposed to a lot of blood. And if it senses low oxygen dissolved in the plasma, then it releases erythropoietin. Well, I'll write that up there when we talk about red blood cell formation, and triggers increased red blood cell formation, all right? If someone has a low hematocrit, let's say a female has 32% hematocrit instead of 36%, what's gonna happen to her viscosity? Viscosity will actually be lower. Viscosity is thickness, okay? So if you have fewer red blood cells to the volume of blood that you have, then it's gonna be thinner. And peripheral resistance will go down, but that's not always a good thing. It means you have fewer red blood cells to transport blood. So in relationship to what we talked about Tuesday night with blood pressure, the same factors that are going to increase viscosity as far as increasing cells are going to increase hematocrit, all right? So if somebody has a condition called polycythemia, it's really just a generic name meaning too many blood cells. But polycythemia would show up as a high hematocrit and high viscosity. What can trigger someone to produce a lot of red blood cells? Living in a higher elevation, or at least being there for more than 3 weeks, is one of the body's abilities to adapt, is to produce more red blood cells. Blood doping, all right, so storing cells, packed cells, and then adding them to your body before an event that you might think you would need additional oxygen, whether that's legal or not. And then there are certain diseases, okay, where the body just makes too many red blood cells or too many white blood cells. Or dehydration. So we can change either factor. You can change the amount of fluid, or you can change the amount of cells, all right? You might have a normal amount of red blood cells, but if you're dehydrated or you've lost fluid through bleeding, you can affect hematocrit. All right, so let's take a look first before we look at the different types of cells. Let's take a look at what makes up plasma. Halloween's around the corner. So, question number one, before we get into those components. What prenatal structure, and you thought we were done with that with the quiz, what prenatal structure is identified as the medial umbilical ligament? I'm not sure if I want to have this. The whole thing, the whole column flipped over. Oh, and I do know how to spell umbilical. Okay, we want more time? Which of the following determines the radius of a blood vessel? Radius is half the diameter, okay? So, does the sympathetic nervous system both dilate and constrict blood vessels? Does it do one thing and the parasympathetic does the other? Or does the parasympathetic system both dilate and constrict blood vessels? Okay? And we're talking about primarily skin and skeletal muscle, although the digestive system is involved as well. We're eliminating consideration of the male reproductive pathway, or the reproductive pathway, okay? So without consideration of the penile arterioles, answer for the rest of the blood vessels in the body. So this takes a little bit of thinking back to the autonomic nervous system that was covered in Bio 430. When I talked about it as a system of dual innervation. Most systems, constriction of the pupil, dilation of the pupil, increased heart rate, decreased heart rate, takes both sympathetic and parasympathetic, okay? Some, like the reproductive system, are cooperative, or erection, ejaculation, emission and ejaculation to occur, it takes both sympathetic and parasympathetic. And some events only utilize sympathetic. In other words, only sympathetic is going to the sweat glands or going to the erector pili muscle. So what is true for blood vessels? Do we use both, one to constrict, one to dilate, or just one? If it's just one, then it's low level firing will result in dilation, and high level firing will result in constriction. Okay.
So, I was gonna get this question from this, but when I was taking the quiz, and it asked about the sympathetic norepinephrine, and does it vasodilate and constrict? I assume because it's fight or flight, your blood needs to go to your body, so you can run and do whatever, wouldn't vasodilate, so you have more blood flow? But I got the opposite, it was vasoconstrict.
Should have been both.
It was only two, the opposite, vasodilate and vasoconstrict.
Did I give a particular region? If it was the digestive system, it would be vasoconstrict. If it's the skin or skeletal muscles, it should be both. Giving away the answer. Yeah, but- yeah. So show it to me during break. But it should be sympathetic, okay? So sympathetic controls blood vessels, and blood pressure with the dilation, the radius of the blood vessels goes up or goes down depending on the amount of sympathetic activity, okay? All right, so looking at plasma, plasma is the water of blood and the proteins. And these are the different types of proteins that are present. We'll talk about them a little bit. Albumin, globulin, which is not the immunoglobulin, and regulatory proteins. And most of these, albumin is produced by the liver. Most of the globulin is produced by the liver. Regulatory proteins would be like hormones. Okay, so those could be produced by the hypothalamus or pituitary or adrenal gland if we've got hormones traveling in the blood. And then clotting proteins are also produced by the liver. The liver makes almost all, not quite, but almost all of the proteins that are traveling in the blood. If we remove the clotting proteins, then the plasma is known as serum, okay? So if you work in the ER and someone comes in and needs a vaccination against rabies or snake bite, then those antibodies are gonna be stored in goat serum or horse serum, and that means the fluid of that particular animal minus the clotting proteins, so that it can be stored for a longer period and you don't have to add anticoagulants to it. So if it has all of those proteins, then it's plasma, okay? All right, question 3. Caffeine inhibits the enzyme phosphodiesterase. We talked about that this week in class. What does it do? Phosphodiesterase inactivates cyclic AMP or cyclic GMP, okay? So if caffeine inhibits phosphodiesterase, that means you're going to have more cyclic AMP. If you have more cyclic AMP, which of these things are going to happen? A, B, or C, A or B, or A, B, and C. So by inhibiting phosphodiesterase, we're doing, it's analogous to increasing norepinephrine, right? If you're inhibiting phosphodiesterase, you're limiting the breakdown of cyclic AMP, which means you're gonna have more cyclic AMP, and that's what norepinephrine does, okay? Just doing a little bit of review before your exam. Or if you don't like the word exam, your summary activity. Okay. Anybody want more time? Okay. Okay. Question 4, before we move on to blood. Which of the following would result in an increase in end-diastolic volumes? So what is diastole? Heart rest or heart work? Heart rest. So at the end of the heart resting, meaning just before, at the time that what valves are closed, end-diastolic volume is going to be what? The maximum volume or the minimum volume? Maximum. So, because we have ventricular filling during diastole, right? So at the end of diastole, that occurs when the AV valve open or close. What happens is, if diastole is ventricular filling, then are the AV valves opening or closing? It's a sequential event question. For ventricular filling, do the valves have to be open or closed? Open. So at the end of ventricular filling, do the AV valves open or close? They're going to close. That's what stops ventricular filling. And they close because the ventricles are in systole, they are contracting, okay? So I'm taking you through this step by step to show you that this is something you can figure out. So if diastole is rest, if the heart is at rest, atrial pressure is higher than ventricular pressure. So atrial pressure is allowing blood, pushing blood into the ventricles, which means the AV valves are open. If it's the end of diastole, that means ventricular filling has stopped, which means the valves have to have closed, and what closes them is ventricular contraction, which increases the pressure greater than the atrial pressure and pushes the valves closed, okay? So at that, which of these is going to result in an increase in end-diastolic volume, which is another word for venous return. Venous return is what causes end-diastolic volume. Without venous return, end-diastolic volume would be 0, right? It's the blood, the venous blood returning to the heart is measured as end-diastolic volume. So venous return is all of the events that's returning blood to the ventricles. So exercise, going to increase venous return. Is aldosterone activity going to increase venous return? Think each of those through, which of them is going to result in more blood in the ventricles by the time the atrioventricular valves close. It's a mark all that apply question. talked about B, C, and D on Tuesday. Two of them have the same function, one does not. You're either gonna include both of those two, or you're gonna exclude both of those. They have different mechanisms by which they work, but they have the same result. How does digitalis work? Well, what does it do, first of all? It does two things. Slows the heart rate down by blocking sympathetic and increasing vagal effects. If we slow the heart rate down, what's going to happen to venous return? Venous return drops or increases with a slower heart rate? Increases. We have a longer time for filling. So there's more, with a low heart rate, there's more time for blood to go into the ventricles. What happens to contractility? Contractility increases because there's more calcium in the cell, okay? So there's going to be a greater venous return because of the longer rest period. What if I had acetylcholine up there? What would happen to venous return with more acetylcholine? You would have increased venous return, you would have a slower heart rate, you would have more filling time. So does that affect contractility, or does that affect Starling's law? Starling's law, because we're stretching the heart wall out more to give us a greater force of contraction. Okay? All right. So looking at these proteins, albumin is the one of the more important ones as far as what we're going to be considering for this unit. Because albumin is an osmotic regulatory protein. So far, in your career in Bio 430, 431, we've talked primarily about sodium affecting osmosis. We did that with aldosterone and ADH and antidiuretic hormone, and H1H protein peptide, that wherever sodium went, water followed. That was our osmotic ion. But albumin functions as an osmotic protein. It's too large to leave the capillaries. And we'll come back to this concept, not next week, but the week after, when I introduce you to the lymphatic vessels. So if we have the arterial system, if we look at the cardiovascular system, and we have the arteries carrying oxygenated blood to the capillaries, and the capillaries are where we lose any kind of muscle, so they have the thinnest wall. And we talked about this effect when we talked about pulmonary edema and systemic edema. So the pressure within the vessels pushing the fluid against the vessel wall is our blood pressure. Also known as, what's another word for blood pressure? Considering the force of the water against the vessel wall. What's the word for water? Hydro. So blood pressure is also known as hydrostatic pressure or hydrostatic tension. Closest to the heart, blood pressure is going to be higher than on the opposite side of the capillary, so we're farther away from the heart. So relatively, we're going to have lower blood pressure here, okay? In the middle, where we don't have vessel walls, there is still significant pressure to push water across the capillary wall. When this happens a lot, we call it edema. It happens to the alveoli, it happens into the skin. It happens anyway, we just don't notice it because we usually bring out most of that water back into the blood vessels, okay? In addition to hydrostatic pressure, we have albumin being carried, synthesized by the liver, and being carried by this is not the same albumin that makes egg white, that's spelled with an E, not an I, okay? We're talking about egg whites floating around in your blood. So this has an osmotic pressure, so it has a force that's keeping water from being pushed across. But we still lose water, okay? We lose less water the closer we get to the veins because pressure is less. But since we've lost water, what's going to happen to our albumin concentration? The same amount of proteins, but now we have less fluid. So the relative numbers are going to go up. The concentration factor is going to go up. So since we have essentially more albumin per unit of volume, osmotic pressure is going to be higher on this side of our capillary bed compared to this side. Get all my numbers right. So blood pressure is higher on the arterial end, osmotic pressure is lower, and the reverse occurs when we get to the venous end. We've lost some fluid and we're farther away from the heart. For both those reasons, blood pressure has decreased. Because fluid is lost, our concentration of albumin is higher, so osmotic pressure has increased. And that actually results in some water returning to the capillary beds, okay? But not all of the fluid returns. And as we'll see when we start talking about lymphatic vessels, we have lymphatic capillaries that are blind ending, meaning they're not continuous. They're like a little tube that starts there. And as fluid builds up around the capillaries because of this fluid loss, it pushes open spaces between these epithelial cells, and water moves into our lymphatic capillaries. It's a lot easier to move into here than it is to move into here. So any fluid that's not returned to the cardiovascular system at the venous end of the capillaries is going to enter into our lymphatic capillaries. They're at a much lower pressure. And when we start our lymphatic unit, we'll follow this back to the heart, because it does eventually get carried back to the heart. But as you can see out in the connective tissue, this is open. Whole cells can move through here. Cells can't move out of here, but whole cells can move into here. So pathogens can move in here. Microbes, bacteria, and viruses. Tumor cells, if it happens to be around a metastatic tumor site. And we don't want to just dump all of that into our bloodstream. And so it's going to be sent through lymphatic tissue, such as the tonsils, such as the lymph nodes, or the spleen, to get exposed to lymphocytes. So that's where we're headed with our blood cell discussion, okay? All right, so back to albumin. What do you think is going to happen to this fluid loss if the liver is diseased and it's not producing as much albumin as possible? Hepatitis, cirrhosis of the liver, liver cancer. One of the signs is a distended abdomen, okay? Where fluid builds up from capillaries forming the peritoneal lining and covering of the abdominal cavity. Because with less protein, because the liver is not able to make it, osmotic pressure drops even lower, and there's less opposing force to the fluid that's being pushed across the capillaries. So more fluid leaves the capillaries and builds up in the peritoneal cavity. Same thing is seen with someone who has a low protein, a high protein deficit, where they don't have enough protein in their diet. You see the pictures of kids starving in other countries, and they have skinny arms and legs with a distended abdomen. That's fluid in the abdomen, because they don't have enough protein, sufficient albumin, to keep the fluid from leaking out of their capillaries. And so it's essentially a form of edema in their abdominal cavity. Okay? So albumin is one of those osmotic regulatory proteins that is opposing the pressure of the fluid against the thin capillary wall. All right, globulins are not immunoglobulins. Those are made by lymphocytes. Globulins are involved in transference of globulin. It's how we transport iron. Okay? Lipids do not dissolve we don't transport oil droplets in our blood. So we have to coat them with protein to get them to be soluble in the blood, because they're a non-polar covalent. Water is a polar covalent. Okay? In fact, we talked about just a few days ago, we talked about the superior mesenteric vein, the portal vein, carrying high concentrations of amino acids and simple sugars. It does not have high concentrations of lipids, because the lipids, as they leave the intestinal walls, coated by protein, are too big to get into the capillaries in our small intestine. They go into the lymphatic capillaries and are taken up to the heart And so it's our hepatic artery. When we get to the digestive system, I'll emphasize that. And it's the hepatic artery that's high in lipids and oxygen, and the portal vein that's high in amino acids and simple sugars. Okay? The other immunoglobulins are made by our lymphocytes. Then we have clotting proteins, as we'll see in lecture next Thursday for you guys. Liver makes clotting proteins too. So before a clot is activated, these are dissolved in the blood. And then obviously endocrine organs are going to make our hormones that are also being transported. That's what we call the plasma. Okay, the water plus these proteins and ions that are in the fluid. All right, so let's look at the cells now, or the formed elements. And the first ones we're going to look at are the most numerous, the red blood cells. So the red blood cells are the smaller. They're about 6.5 to 7.5 microns. Our white blood cells are between 10 and 18. And then we have the tiny little platelets that are about half to 1 micron. Okay? So when we look at hematopoiesis, hematopoiesis is a long, I always think of cooking cakes in Hawaii. Somehow poi and hematopoiesis come out similar in my mind. The hemato refers to blood. So specifically, red blood cell production is going to be erythropoiesis. Hemato is just either red blood cells or white blood cells or platelets. So what we have up here is specifically erythropoiesis. Erythro meaning red. Erythema is reddened skin. And both white blood cells and red blood cells have a common stem cell, okay, called a hemocytoplast. I'm not going to ask you to recognize that in a bone marrow slide. The only difference between that and an erythroblast can be pretty difficult. But you can see a trend going on here. Notice how large the nucleus is? And it gets smaller and smaller and smaller until it's extruded from the cell. What is the what's the primary protein for which the DNA is being copied? What is the RNA is being transcribed a code for? Globin. Hemoglobin, the heme has to do with the iron. The globin protein. So essentially by the time the erythrocyte enters into the circulating blood, it's a plasma membrane sac of hemoglobin. And this dark blue that you see here in the cytoplasm are the ribosomes in making the ribosomal, transcribing the messenger RNA into hemoglobin. And if you recall from 430, when the DNA is being transcribed into messenger RNA, it has to be uncoiled. And we call that euchromatin, because it has to be able to uncoil and spread apart to be copied by messenger RNA. And when it's not being copied anymore, it's heterochromatin. So that's what's happening as we move through these various stages, is the chromatin is becoming supercoiled. So it's as packed as closely as it can be and extruded from the cell. This usually happens before it leaves the bone marrow, and because it's just taking up room that could be occupied by hemoglobin. Okay? Now, sometimes the body is triggered if you need extra red blood cells, you're at high altitude, or you've increased your exercise, or whatever reason anemia's been caused and your body is trying to replace the lost red blood cells. You will see this reflected by a high number of cells in the blood that have these little blue dots or strands. And that's because the red blood cells are being produced too fast. They're entering the bloodstream before this can be extruded. These are ribosomes and ribosomal ER. The same stuff that causes this to look blue, okay? So it's just not yet finished being processed and moving into the circulatory system much too rapidly.
Will it finish processing in the circulatory system, or it's not useful?
Not usually. I mean, it can still carry oxygen, it's just not as much. So the lifespan of a red blood cell is approximately 120 days. Before birth, in the fetus, this is going to, erythropoiesis is going to take place in the liver, in the spleen, and in red bone marrow. And the red bone marrow is found in epiphysis, or epiphyses, and the long shaft of the bone, the diaphysis. Okay? So this is in fetal red blood cell production. By the time you're an adult, it's only in red bone marrow. And it's in spongy bone, not in the diaphysis, not in the medullary cavity. So it's in the epiphyses of long bones and in flat bones. It's in flat bones here too, but there's more of this other. So it's gonna, if they need to do a quick bone marrow sampling in the ER, they go into the sternum. Okay? If they're doing it for bone marrow transplant and so on, they do go through the iliac crest, and they can do it with the vertebra. So epiphyses of long bones and sternum and the ilium. The liver and the spleen now become places where red blood cells are broken down. So we'll talk about that process a little bit more. When red blood cells are broken down, there's a pigment that's released. Do you know the name of it? Bilirubin, okay? It's actually the bilirubin from the liver. We'll talk about this with the digestive system a little bit more. It's the bilirubin because the liver is the site where red blood cells are broken down. There's special macrophages. We don't generally find macrophages in the blood. They're in connective tissue. And there's special macrophages in the liver that will break down the red blood cells. And the bilirubin injures the digestive tract, injures the small intestines. And that's what gives the brownish, yellow-brown color to fecal matter. So all of these small, dark nuclei cells, they look a little bit like spermatids, the early spermatids, are red blood cells that have just about lost their nuclei. And here you can see a progression from a proerythroblast to an erythroblast. See how the nucleus is getting smaller and smaller. And here the cytoplasm is not nearly as blue. It's almost a grayish color. And that's just about to lose its nucleus and become a typical red blood cell that we find in the bloodstream. So red blood cells don't have a nucleus. So there's two major things that they're not capable of doing. What do we need a nucleus to do? Pardon? To divide. So red blood cells don't divide. That's why their lifespan is limited. Now the stem cells in the bone marrow would. Okay? But the erythrocyte out in the blood itself would not. And we need it to make messenger RNA to make new proteins. So all the messenger RNA has been made before the nucleus is lost. And so it can't make any more after that without the nucleus. We can't make any more of the messenger RNA. But most of our red blood cells have plenty. So here you can see that red blood cells have a distinctive biconcave shape. Anybody know why? Why they're not round spherical cells like a blastocyst or a basketball? What does this provide? Yes?
High surface area?
Yes, high surface area without a lot of depth, so that anytime for both the movement of oxygen into the cell as well as out. Because oxygen is going to be binding to iron ions, and at any given time, it's not too far from the surface. Whereas if we had a round spherical cell, hemoglobin that was in here would be quite a ways to diffuse into or out to get to the tissues. The next image just shows some of the complexity of the proteins in keeping this biconcave surface, kind of like a bunch of tetrahedrals here. This is what bioengineering students worked on a while ago, figure all this out. And the closest we'll get to look at this is what happens to sickle cell and sickle cell anemia in a few minutes. Okay. So the hemoglobin has two different types of proteins alpha and beta, and there's even a fetal form that has a higher affinity for oxygen. We'll look at that more closely with the respiratory system. But we have two different types of hemoglobin, A and B, and there's this iron molecule associated with nitrogens, and that's where the oxygen binds. So oxygen binds as a molecule, O2. So we have to end up with 8 atoms of oxygen in each of these hemoglobin molecules. It's really cool when we get to the respiratory system and we look at what causes, we don't want a constant affinity. Okay? Well, do we want high affinity or low affinity between hemoglobin and oxygen? We want a high affinity in the lungs, so that even if you were at 5,000 feet elevation, you could still saturate your hemoglobin 100%. Because we couldn't live on the hemoglobin we just carried dissolved in the plasma. But if we had a high hemoglobin affinity in the lungs, when that blood carried that hemoglobin to the tissues, you would have a problem. The oxygen wouldn't come off of the hemoglobin because there would be a high chemical attraction between the two. And so what we have is a molecule, the hemoglobin molecule changes in the iron, changes its attraction, chemical attraction for oxygen based on conditions, especially things like the presence of CO2 and acidity. So when we get to the tissues and there's high CO2 and low pH, that causes the affinity to drop and oxygen separates from iron. We don't want to have low affinity because in the lungs we wouldn't be able to saturate our hemoglobin with oxygen. So it works out that it changes depending on what region of the body we're in. All right, so hemoglobin is measured in grams per deciliter. So this is how many grams in 10 liters. And back in the day when students could poke their fingers and test their own, there's a spectrometer that is more accurate in measuring hemoglobin by measuring the reflection of light. But here is a chart that students would use. They would glance their finger, poke their finger, and then put a drop of blood on a piece of blotting paper, and then slide it. These would have holes poked in them, and then you would slide your fresh blood up and down, and see what color it matched. And if it was more orange, it had less hemoglobin. If it was a darker red, it had more hemoglobin. Okay? It's kind of gross because the back side of that was just weird with everybody's blood. Because it was fresh, but you slid it under there. So here are the ranges in hemoglobin. You can see again the male has more, just like they had a higher hematocrit. It's just a different way of measuring oxygen carrying content, whether you're doing hematocrit for cell volume or hemoglobin. So again, males have more because of the amount of muscle mass. Females have lower, plus females in childbearing age are going to be losing fluid with menstruation, so they typically have a lower amount. The lowest mine has ever been is 8. And I wasn't bleeding, I was pregnant with twins. And I thought being tired was just, so I had twins. But I didn't want to take iron pills, so I ate a whole bundle of collard greens every day for lunch. All right, so let's look at I said polycythemia was a lot of red blood cells, but it could be caused by different conditions, okay? High altitude being the least traumatic of them, or disease resulting of them. And when we don't have enough blood, or we have not enough protein to make blood cells, the decrease in hemoglobin, or the decrease in hematocrit, or the decrease in red blood cell count is known as anemia. So I've given you hemoglobin, I've given you hematocrit. The numbers for red blood cells are approximately 4.5 to 6 million per cubic millimeter, and that's sometimes also given as a microliter, but it's the same thing, okay? So here's different causes of anemia, meaning your hematocrit is below 12. I mean, your hemoglobin is below 12, or your hematocrit is below the value for male or female. So iron deficiency anemia means your body's capable getting the protein, but you're not taking enough iron to stick into the hemoglobin for it to be able to carry oxygen, because it's the iron to which it attaches. And in fact, this image is of iron deficiency anemia. And you have enough blood cells, they just don't have the iron in the hemoglobin, so they're pale. People that are anemic, you pull down their lower eyelids, it's gonna be very pale on the inside. Their fingernails may be a little cyanotic, but the quickest way to check for it is looking on the lining of their eyelids. All right, aplastic anemia means the bone marrow is not producing red blood cells from the stem cells. There's been loss of the stem cells for red blood cells. Sometimes the cause is unknown. It could be exposure to drugs or radiation, where you don't have enough stem cells. A lot of chemotherapy damages the stem cells, and anemia is a side effect and oftentimes the cause of death in people who are being treated for cancer. Hemorrhagic is loss of blood. Okay, so it might be a bleeding ulcer, it might be, trauma from an accident. Hemolytic is anemia where the red blood cells are rupturing. This can sometimes be caused by genetic conditions, or malaria is a parasite that in its life cycle passes through the red blood cell, and in severe cases can cause the red blood cell to rupture in a form known as black water fever, where it causes the blood to turn dark. Sickle cell anemia is an inherited condition with a single amino acid substitute. The normal glutamic acid is replaced by valine. And this is the messenger RNA code that's being copied wrong. And so what happens is the red blood cells aren't always in this sickle shape, but when the oxygen dissolved in the blood drops, then it causes the red blood cells to collapse, and it causes them to stick in smaller vessels and block blood flow, and therefore you have loss of oxygen, not only from not being able to transport it on the cells, but because the blood can't get to an organ. So there can be organ damage, joint pain. Interestingly enough, you've probably heard, and if you've taken micro courses, individuals with sickle cell anemia have an immunity against the parasitic invasion by the malaria parasite, so they're protected against the malaria parasitic infections. Some people have traits so that they don't have it all the time, but it's triggered, like I said, with the exposure to oxygen. So athletes, there's football players that have this that go and play Mexico City or in Denver, and they have to be careful with the oxygen concentration in those areas. All right, pernicious anemia. This is a protein characteristic here. Lack of vitamin B12, which is a vitamin that increases protein synthesis. And it can be due to two different causes. All right, you could have a decrease of vitamin B12 in your diet. So essentially, pernicious anemia is a lack of vitamin B12. It can be dietary in cause, or there can be a loss or a lack of intrinsic factor in the stomach. This is from cells that line the stomach and usually release enzymes that help with some protein digestion. They also make this intrinsic factor that is required for absorption of the vitamin B12 in your diet. So if you have vitamin B12 in your diet, but you lack the intrinsic factor, you're not going to absorb it, okay? And if this is the case, it's usually taken by injection. In this case, the most common way in which people lack it in their diet are if they're true vegans, where they don't eat any animal products. Because vitamin B12 is obtained from animal products. So I'm a vegetarian, but I'm not a vegan. I love cheese and milk and yogurt and all that kind of stuff. So I'm what they call, or what's called lacto-ovo. Lacto for milk, ovo for eggs. so dairy and egg products, but fish and fowl. And I remember my oldest son was in daycare after kindergarten. He came home at the age of 5 with a little list of, my favorite food, my favorite color, my favorite this and that. And one of the comments was, my favorite food is chicken McNuggets. I'm like, wait a minute here. So I talked to the daycare providers and I said, we're vegetarians and I prefer if you don't, feed Chris meat. And because we had said, well, honey, you're not supposed to be having meat at school. He goes, well, Mom, they told me chicken wasn't meat. So some people think that fish, something that's not red meat, is not meat, so poultry and that type of thing. So sometimes you just have to explain a little bit for that. So if you take pills, if you're a vegan, then you need to take it a pill form, and that's still derived mostly from animals, okay? But it's been purified. You're not going to have the animal fat products in there. So just taking it as a pill, if you lack the intrinsic factor, is not going to work because you have it, but you can't absorb it, okay? So an intramuscular injection of vitamin B12 is the quickest form of that. But most people will they're tired, they'll pick up a bottle of vitamin B12 pills in the grocery store or in the drugstore or something. So a gastric bypass is a common way of losing significant stomach surface area, and so that's a risk for loss of intrinsic factor. If they're removing 2/3 of your stomach, they're removing 2/3 of the cells that produce intrinsic factor. I told the class last night, it's not a story. It involves vitamin B12 injections, but it's not directly related to anemia. And it was the first case in which the RNA sequencing of a virus was used forensically. And this woman was married and had a family, and she was having an affair with a guy who was also married. I don't know if he had a family or not, but he was a doctor, and they had a long-term affair, and they discussed divorcing their partners so they could get married. So she did. She divorced her husband. He never did divorce his wife. So after like 5-6 years, she got tired of waiting around. So she was dating other men, but he kept coming over and seeing her, and she couldn't say no. And she finally met one guy that she decided she wanted to marry. So she told this other man that, I'm not going to see you anymore, don't ask me, it's over, it's done with. So in a few days, he called her up and he said, I'm going to come by tonight and I think you need some vitamin B12. Now I have no idea what kind of control he had over her, but at 1:30 in the morning, he came over to her house and injected her with vitamin B12. Apparently something he had done off and on when they were dating. Within 2 months, she became positive for HIV. And she had no other risk factors. She hadn't had any other blood products. She hadn't slept with anybody else but her fiance. And so she went to the police and she said, what did that happen? And she said, I believe this doctor infected me with HIV when he gave me that injection. Well, he was otherwise well respected, and they hesitated to accuse him of this, but they had fortitude. They got a search warrant, and they went to his office, and he was not very smart, because in his lab refrigerator he had a vial of blood drawn from an HIV positive patient of his, drawn on the day that she had told the police department that she had gotten her injection. And they were able to trace, through the multiple divisions of the viral replication, the same sequencing of the virus that she had in her blood. And not only that, this patient was also hepatitis infected. I don't know if it was C or whatever, but she had the same viral strain of hepatitis. And he was convicted of attempted murder, and then within about 6 years, I think she actually died of HIV virus. And it was changed to murder, but it was, I just think of it every time I talk about the vitamin B12, because it was the first time that kind of sequencing was be able to use to prove that he was the source of the virus that she was given. Okay, do you want to take a short break before we finish with white blood cells, or do you want to go through?
Go through it.
Okay. So we have 5 forms of white blood cells. These white blood cells are functioning in defense. To some degree, red blood cells will also transport carbon dioxide and will affect pH by buffering hydrogen ions. But their major function is oxygen transport. And they're like the semi-tractor trailers that we see on the freeway. They don't get on and off the freeway, they don't go in and out of your blood vessels, but their function is within the blood vessels to transport oxygen, all right? White blood cells, your blood is supposed to be sterile. It should not need defense cells breaking down and taking up bacteria and viruses. We do have the spleen, the only source that filters blood, but basically our white blood cells from the bone marrow enter into the bloodstream, travel to various sites in the body, and then leave it to do their work in the connective tissue around the body organs, okay? So they're like you and I that are getting on the road and driving to school or to work or to the gym or whatever, and we don't hopefully live on the road or other places, and that's our form of transport. So that's how the white blood cells use the blood vessels, is as a form of transport. You guys remember what blood vessel it is that white blood cells pass through to leave the cardiovascular system? The process is diabetes. The vessel.
Oh, venules,
Venules, and specifically
the
the post-capillary, yeah, right after the capillaries. So we're going to talk about white blood cells. I want you to know both their frequency, and then they're described by whether or not they have granules. All of them actually have granules, we just can't see them in the light microscope, okay? So, I want you to know their basic functions. I want you to know whether they're the most, frequency, 1, 2, 3, 4, 5, which one's most frequent, and so on. Basic appearance. So neutrophils are the most common. Approximately 70% of all the white blood cells, if you were to have a differential white blood cell count, when they give a number to each, are going to be neutrophils. And all white blood cells, except for basophils, are phagocytic. Okay, meaning they do endocytosis of bacteria and viruses and foreign cells. Neutrophils are the most common, so if you have an infection and you've got pus, most of that yucky white pus is going to be dead neutrophils and dead bacteria. The appearance is polymorphonuclear, and sometimes called a term of polysegmented. So the nucleus has thin segments and then a big fat nuclear glob, but it's all one nucleus, okay? They're called neutrophils because they don't prefer either an acidic or a basic pH dye. Their granules are relatively small, so they have fine, usually pink staining background of granules. And most of these are chemicals to break down the bacteria and viruses that they ingest, and chemicals that they release to attract other white blood cells. So, fine granules, pink staining. All right. The next two, these are called granulocytes because of the appearance of the granules. All right. The next two are a bit smaller. These are about 12 microns, 12 to 14 microns. These are around 10 to 12 microns in diameter. So you can see they're a bit, this is 7, this is a little bit larger than that, 12 microns or so. And the next two types have what we call horseshoe or bilobe nuclei. And in lab next week, let me draw it a little bit smaller. In lab next week, we'll spend some time looking for them in the microscope. Actually, in between. Too big, too small. Do it just right. These are whole cells when we look at them in the microscope, so they're not sectioned. This has a kind of bilobed or horseshoe-shaped nucleus. The granules are large, but they don't obscure the nucleus, and they are red to orange colored in stain. They are acidic loving, so these are identified as eosinophils. So there are, fourth in frequency. Neutrophils are number 1. And these are number 4. These are also phagocytic. And they are phagocytic primarily for parasites. So this is going to increase in parasitic infections. You let your child play out in the sandbox with the cats and the dogs poop in, or you eat undercooked meat, pork, and it has worms in it. I'm not trying to get you to be vegetarians, but you're going to see an increase in eosinophils. Okay? They also increase in allergic reactions, not because they release histamine, but because they break it down. Histamine is going to increase capillary permeability, so it's going to result in more redness and swelling, and eosinophils help to remove that. All right, the last of our granulocytes is the least common, number 5, and it's usually 1 or less than 1%. And this is a basophil. So it's stained with basic higher pH stains, and it's also horseshoe shaped. But its granules are so dark that they obscure. They're the same color essentially as the nucleus. They're dark blue to dark purple, and it's almost, if not impossible, to see the nucleus when you look at this cell. It is most easily confused with the next cell we're going to talk about, which is slightly smaller, just barely bigger than a red blood cell, about 10 microns. And this one is 10 to 12. And this is the lymphocyte. The lymphocyte is mostly nucleus. I'll come back to this in a moment. I just want to compare these two with you. It's mostly nucleus. And so they both have this dark blue color. However, lymphocytes don't have granules. So when you look at them, you want to look along the edge of the nucleus. It'll be smooth. Whereas if you look at a basophil, the nucleus is, the cell is going to be this irregular surface where the membrane is draped over the granules. Okay? So here you can see that right along the edge here, how it's irregular. Okay? And again, the lymphocyte is a bit smaller, it's just slightly larger than the red blood cell. So basophils are not phagocytic. Remember I said they were all phagocytic except one. Basophils are not. And they release the histamine that the eosinophils are breaking down. Anybody remember the other cell type that makes histamine? Starts with the letter M. And it's not a red blood cell, it's not a blood cell, a white blood cell. Sorry. What's a cells? What are cells attached to?
Mast cells.
A mast, there you go. So mast cells are kind of a triangular orange granular cell that makes histamine. So these release histamine in inflammatory reactions. Okay, so those are the 3 granulocytes, and then we have 2 that don't demonstrate granules if you look at them in the light microscope at least. So here's the basophil. You can see it's hard to see the nucleus. You can see that it's irregular. Now let's compare that to a lymphocyte. See how smooth this is right along the edge here? Compared to this irregularity. Okay? So lymphocytes are number 2 in frequency, about 20%. And we're going to talk about these more, because this is where our immune system is based on. And these provide specific immunity, meaning they don't work unless there's receptor recognition of whatever it is they're attacking. The plasma cells are a form of activated type of a lymphocyte. Okay, so we'll talk about them in a whole lot more detail in a couple weeks, or 10 days. And then finally, the third in number are the parents of our macrophages, which are the largest of all of our cells. And they're so large, they're sometimes deformed by the red blood cells around them. They're about 18 to 20 microns, so almost 3 times larger than a red blood cell. And they don't demonstrate granules either. These are monocytes, and they will become macrophages. They often have a kidney-shaped nucleus. Looks like it's been folded over on itself. And in that nucleus, you often see it's splotchy. You see these little white spots. Okay, see how it's slightly indented here? So that's a sign of a monocyte, and these little white splotchy areas in the nucleus as well. So monocytes become their active form, their functional form is as a macrophage. So what organelles are they going to have high numbers? Lysosomes. Okay. All right, so the last cell I'm going to mention is not a cell, it's a platelet. Okay? So platelets, let's go back to that. Platelets are, have we had 5 questions yet? Okay, let's do that. The malaria would most likely result in an increase of which of these cells? So we talked about malaria and hemolytic anemia. So what cell does it infect? Red blood cells. As a what? What class would you be taking if you studied malaria? Well, you probably talk about it in microbiology. But the classes that are taught that describe malaria, describe nematodes, describe filaria. There is a worm that invades the body and gets into the lymph nodes and causes elephantiasis, where the lymph nodes are blocked, and we talked about the edema. And so the legs can increase to this size. The scrotum can be big enough to reach the floor. And the lymphatic fluid isn't being able to get back, and that's because of a nematode, a worm invasion. So those are all parasites, as is malaria. So what blood cell is going to increase if you have a parasitic infection like malaria? Okay? Can I give you enough clues for that?
Mm-hmm.
So last thing here are platelets, which never even have their own nucleus. They have the same stem cell as white blood cells or red blood cells, but their cell is so large, mega means large, karyo refers to the amount of cytoplasm. So these are large cytoplasm cells that are so large they are trapped within the bone marrow. This whole white cell is a megakaryocyte. You can see developing eosinophils here. And another one up here with that orange cytoplasm. And this whole cell right here is the megakaryocyte. So just membrane sacs pinch off from the edge of it and contain a series of chemicals we'll talk about next Thursday. And these are the platelets. So platelets do not result in a blood clot. They can help to slow down bleeding by sticking to each other, and they can trigger the formation of a blood clot. But a blood clot, as we'll see next Thursday, is specifically the formation of threads, protein threads within the blood that trap water and keep it from flowing. Platelets are just going to stack on top of each other and help to block a hole in the blood vessel, and they can trigger the polymerization of those proteins, okay? But a platelet plug is not the same thing as a clot. All right, we'll stop there. Thank you for your patience, because this material will not be on Tuesday's exam, but it will be on our blood and immune exam. By the way, in case you haven't noticed, that exam is online, not right now. It will be available for about 6 days, from the time we stop this unit, and, it has a defined time limit, but you can take it any time during that next week. So we're gonna finish, and then we'll start the next unit, which is respiratory. But you can take the immune system exam at any time during that period. We'll start a clock, like 90 minutes or whatever, and, but you can start it at 2 o'clock Tuesday afternoon, or 4 o'clock Thursday morning, or whatever, okay? All right, so, why don't you take a break? I'm gonna go, in about 5 minutes or so, I'm gonna finish up the review that we looked at with the slides on Tuesday. Look at some blood vessels and look at some tables of, if this goes up, what happens to cardiac output, or if this goes down, what happens to venous return. And that'll take about 20 minutes, okay? So you're welcome to study, review blood vessels, or I'll start that. We did a little bit of it Tuesday night. I'm just gonna go back and finish that up. And that'll take about 20